An evaluation of a perinatal woman for depressive symptoms must also include a careful consideration of differential diagnoses. Approximately 70% of postpartum women experience a set of symptoms called the baby blues that peak between 2 and 5 days postpartum and generally resolve within 2 weeks. A woman with the baby blues may feel weepy, have mood lability, irritability, or anxiety. However, these symptoms do not impair function. While the baby blues can be considered a normative experience, women who have the baby blues are at increased risk for postpartum depression, and so their symptoms should be followed over time. The most common type of mood episode in the postpartum period in a woman with bipolar disorder is actually a major depressive episode. Thus, it is important to always inquire about previous manic episodes, a family history of bipolar disorder, and any personal history of adverse reactions to antidepressants when evaluating a perinatal patient for depression. While depression and anxiety are highly comorbid conditions in the general population, the relationship is thought to be even stronger in the perinatal period. Depressed postpartum women are more likely to present with anxious features as compared to women with depression at other times of their lives, and approximately 50% of women who are depressed during pregnancy or the postpartum period can be diagnosed with a comorbid anxiety disorder. An astute clinician must thoroughly explore anxiety in the review of symptoms. Finally, postpartum psychosis is a rare condition that is most commonly associated with bipolar disorder. All perinatal women presenting to a psychiatrist should be asked about any experiences with auditory or visual hallucinations or unusual or paranoid thoughts. While exploring the domains of suicidality and homicidality, it's important to inquire about any thoughts of harming the fetus or infant. Importantly, postpartum intrusive thoughts of accidental harm to the infant are nearly universal, and approximately half of postpartum women may experience unwanted thoughts of intentional harm to the infant. Thus, when these types of thoughts are revealed by the patient, it's imperative to explore them further for a more complete understanding of the patient's experience. For example, one might inquire about the frequency and intensity of these thoughts, the absence or presence of intention to follow through on the thoughts, and whether the thoughts are egosyntonic or dystonic, and if there is a psychotic origin. Finally, as in the general population, it's important to consider substance use disorders, general medical conditions which may present with psychiatric symptoms, and organic brain disorders. Measurements of hemoglobin and thyroid-stimulating hormone levels are generally recommended, and imaging should be done if there are other symptoms present indicating a primary neurological cause.